Okay, we will get started then. Welcome everybody to our Center for Digital Transformation of Health Clinical AI Seminar Series. I'm Wendy Chapman. I'm the director of the center. This series has been very exciting. We've had some amazing speakers, and today you'll find another amazing speaker talking about not the algorithms, but how do you take these amazing algorithms that people are developing and how do you really implement them into the healthcare system? We know we've had AI for decades, many, many decades, but it's not in routine use. Why not? That's what we want to address. So we're really pleased today to welcome Dominic Dwyer, who is at the University of Melbourne and Orygen. Dom is Australian,
yep,
but has spent a lot of time in the UK at King's College and in Germany, doing research in mental health and digital mental health. He's come back to Australia and has at least one couple of MRFF grants. Two MRFF grants, one that we're collaborators on and really excited to start working with him on that. But it's all really focused on you know, how do you get the algorithms that are already out there into the youth mental care system so that the patients can benefit from them? And how do you develop tools that are actually usable? So really looking forward to Dom's insight today. Thank you.
Thanks a lot, Wendy. Thanks to everyone. Thanks very much. Yeah, I'm really excited to give this talk. It's a new version of an old talk, and it's including completely new material that I haven't presented before. So I really hope that you enjoy it and it stimulates some thought and discussion. Oh yeah, acknowledgement of country. So we acknowledge the people of this land. I've never done this before actually, so I'm going to mess it up. Yeah, the Wurundjeri people, and we acknowledge their elders and other Wurundjeri people who are in the room, past and present. Fun fact is that Wurundjeri people, along with all of the Indigenous people, had a very good understanding of the stars and astronomy. And they required it over the 50,000 years that they were here. And there's a wonderful book that outlines their scientific exploration and discoveries of astronomy that I, recommend. But I'm not going to be talking about stars. I'm going to be talking about AI. I want to convince you that this mission is important. So I know that there's a lot of things in the world that are important. I know that there's a lot of things that are happening in the world at the moment that are very important. And I know that, you might have had experiences with different health conditions or your families, and they are very important as well. But I want to convince you at this time, in this talk, that mental health is very important. So a background to the need for artificial intelligence, especially in youth. So mental illness is a youth condition. It starts in youth in 75% of the people, up to 75%. It's more prevalent in youth than any other age group. So mental illness can be characterized as a youth illness, just like Alzheimer's can be characterized mainly as an older age illness. And the thing is that when you've had a mental illness in your youth, 85% of those people will have comorbidity, that is other mental illnesses when they are older. And also they'll be at 30 times the risk of future mental illness. And so that means that if you have, say, for instance, anxiety or depression when you're young, then you're more at risk of other things when you're older. And so that there's a continuum of mental health throughout the lifespan that fundamentally begins when we're young. Here's some more statistics about the risk of other disorders after a major depressive disorder. You can see that substance abuse goes up, and then even schizophrenia goes up as well. And the thing is that in youth at the moment, and especially over the last few years, mental illness has been basically on an exponential rise. And so here's 70,000 people surveyed in the US, and this is major depressive episodes. So this is a really serious thing. These are the increases between 12 and 25 years, as opposed to other age groups like 35 years of age that you can see there down in orange. What if you look at something else like the days per month with poor mental health? And this is over 100,000 participants surveyed. You can see that the trends are also exponential. Let's look at Australia and let's look across illnesses. And you can see there that depression or anxiety is really the only thing that's very notably increased over the last few years, 5 years. And so this increase is quite staggering when you think about it. During this talk, this section of the talk, I'd also like you to think about what would happen if one of these other illnesses, for instance, cancer, showed the same rate of increase. This would be fairly newsworthy, to say the least. And what I'm going to show you is that mental illness can be as significant as some of these other illnesses. So one of the ways that it can be significant is that mental illness can cause self-harm. So it can cause people to harm themselves. And self-harm is going up over the last 10 years, especially in girls. So this is in the US, this is for the UK, this is for Australia, and this is for New Zealand. So all around the world, including in Santiago, where I visited to talk about this work around a year ago, it's increasing. And I'd like to also make the point here that this is admissions to hospital. So, you know, a lot of people will raise the point that, well, mental illness is just being discussed more. Maybe young people are snowflakes. Well, if they are snowflakes, they're actively harming themselves, you know, and they're being admitted to hospital. It's that severe. And so, again, just shift your thinking to if this was a physical disease that people were admitted to hospital for, these things are going up. You know, let's put aside all of our preconceptions about mental health and mental illness and mental stuff. And ultimately, there's around about 300 to 350 suicides per year between this age group, and 30% of all deaths in the age group. That's much more than the road toll. And yet the road toll you hear talked about almost every day. So that is a problem, and it's an increasing problem. And it's a problem all over the world. There's been around a 50% increase in the prevalence of mental disorders in young people since 2007. And let's compare it directly. So let's try what is often thought to be something that you really shouldn't compare, which is suffering. Let's just do a statistical comparison of suffering, cancer, which over the last, since 1990, the incidence of cancer has been going down, basically for a lot of different kinds of cancer, or has been maintained as stable for others. What about the death rate? Well, that's been precipitously falling since 1990 with age standardized values. So overall, we are winning the cancer fight. It is going fantastic. And one reason for that is the large hospitals that we have and large investments in the space. Now, don't get me wrong, cancer is an awful, horrible illness. And as I said before, you can't compare suffering. There's a lot of deaths happening still with cancer, but the fact remains that if you take the age standardized values, we are doing really well in that space. And if you look at the most recent reports, it's down by about 30%. So that's pretty good. But we're losing the battle against mental illness. So this is the age standardized suicides since the 1980s, and you can see that they're going up quite precipitously, almost at the same rate as the cancer death is going down. And that's why people like the US Surgeon General has called this a crisis. So he's just called it out. He said, look, this is a crisis. We need to protect youth mental health. It's going to have repercussions throughout our society. And if you think about the population statistics at the moment, with birth rates at only 1.5, it means that if you've got a lot of mental illness or other health conditions in youth that have a 30% chance of reoccurring later in life, then you're going to knock out your main productivity class of the population. In a case at the moment where we've got an aging population who needs a lot of help. So it's a problem. UNICEF is also calling it out, and they're saying that it's a challenge ignored across the world. You know, we're calling it out too. So really the question is for me at the moment is how did we let it get this bad? How did we ignore it for so long? And really it's a long story, and you know, I guess I am a bit academic, so I like history. And we've been dealing with mental illness for a really long time, so you know, thousands of years. We've had a lot of different ways to deal with it. So this is trepanation, where people punch holes in other people's heads to let the spirits out. These kinds of approaches and ways of understanding the brain have changed over time. We've tried to intervene with therapies that were effective for us, but not very effective for the person having their brain damaged. And so it was around the early 1900s when someone came along called Franklin, who said that these ways of understanding the soul and the mind may be a little bit misled or unhelpful. These ways of understanding that there are 4 different main types of things in the body of humans that produce disease might be not so helpful for treatment. And so he questioned this and came up with classes for mental illnesses. One of them was schizophrenia, another is major depressive disorder. And he came up with this book here, which is an original picture of an original book back 100 years ago. And realistically, that kind of system or framework is still existing today in the DSM-5 or the ICD. And so we have a diagnostic framework of understanding mental illness. And here's the problem. So this is Craiglin. He's with his buddies down at the lake where I used to work. And this is Alzheimer, this is gout, and this is Nissl. These are sort of very big leaders in the field. This is the clinic where I worked at, the same building actually. It hasn't changed since that time. And this was where they did their lab work, which was just 1 floor down from me. And Alzheimer was actually Craiglin's student, and he found the neurofibrillary tangles that are characteristic of Alzheimer's disease, and that's why we have Alzheimer's disease. So he found biomarkers. Alzheimer, he was investigating schizophrenia a lot more, and he looked at brains of people who had died, so not these images that had other brains, and yeah, he didn't find any biomarkers. And that's why at the moment we've got controversies like this and funding agencies which are putting millions of dollars into undermining diagnoses in mental illness. And yet, and the other thing about it is that our more recent work, like this imaging work, which is extremely beautiful and it's where I started my career, and I think it's extremely important science, but unfortunately it's delivered no biomarkers. And unfortunately, there's been very little clinical translation from all of this work. And so, you know, this is one of the reasons that we're in this situation now. The illnesses that we had identified biomarkers for instance, EEG, epilepsy, using EEG, they're no longer in psychiatry. They're a neurological condition. So psychiatry will always be a domain where we don't necessarily have biomarkers. And once they're found, they'll probably be in another category of medicine. So we're in an area which is the last sort of bastion of understanding, and when it comes to medicine in a broad way. And what is the best we can do in this kind of space? Well, the best we can do is the best we can do for a lot of medicine. And I'd like to point out at this stage that what I'm going to be talking about here really is very similar for most medicine. So what we do, the best that we can do is we get a diagnosis, for instance, people with schizophrenia or depression, and then we see how they turn out. So then we have a diagnosis and an outcome. And using these kinds of approaches, we can develop guidelines. So we can develop what I would say is a wait and see prognostic approach. We develop guidelines with treatments that only have 50% accuracy rates across therapies. And that ultimately leads to sort of these trial and error treatment strategies. And so, for instance, if you are a young person, we can say something like, well, Lisa, 30% of people with your diagnosis will have an episode of psychosis. And you could apply this to most medical illnesses. But the problem with that approach is that, well, at least I don't want to know what the people are going to be in my group. I want to know what's going to happen for me. I don't want to know that 30% of people in this group will develop psychosis. I want to know my own likelihood. And more than that, I'd prefer it if a clinician knew that too. Because the thing is that if we're talking about at least psychiatry and a lot of other medical conditions, then we're talking about either an internal implicit prognosis, or we're talking about an explicit prognosis. You don't treat someone if you think that they're going to get better. And you do treat someone if you think they're going to get worse. So the reality is that you've got a lot of people in these groups with a lot of different phenotypes or presentations. And so the reality is that you've got this diagnosis and 30% psychotic, but as any clinician will tell you, there's all of these other things that can come into the equation, like gender, for instance, or comorbidity in this space, or physical health. And that's the same for any medical condition. That's why we have clinical courses. We don't have natural courses of disease anymore, because we can intervene and the individual aspects of a person will interact with our treatment to produce an outcome. This is a clinical course. Whereas a natural course would be if we had a diagnosis and then that person or any person with that diagnosis always ended up in the same place, because that's the natural course of the illness or disease. So we've moved on from that a long time ago. And the reason is because we're considering all of these different things and we have effective treatments. So then what do you tell a young person if you've got all of these interacting multivariate kinds of ways of understanding risk and their prognosis and their diagnosis? It's really hard. And so what you'll tend to do and what clinicians tend to do is either give them the stats that I told you about before about the group, or not give them the stats and say something like this. You're experiencing psychosis and depression symptoms. You don't really have a diagnosis. We can't really put you into a box. What's the prognosis? We'll just have to wait and see to determine your prognosis. But internally, a clinician will be thinking that they will or won't develop a particular thing. What's the treatment? And let's work together to try different treatments until something works, is essentially what happens these days. That shared decision making, which is incredibly important. And I think that we need to continue that. But at the moment, I don't know whether that is serving us well, or this is serving us well. So that's kind of the problem, that problem statement, that this is why I think that this kind of work is important. And now I'd like to show you that we're working hard to address this with really globally leading infrastructure and also teams. And this isn't really necessarily associated only with AI. It's associated with a change of thinking and a change of policy and a change of a lot of different things. But before I do this, I'd just like to give a little bit of a really important background. And this, again, harks back to this interest I have in history, because I don't like repeating mistakes from the past. So here's the picture again of these dudes at Starnberg Lake. And around about at that same time when they were sitting at that lake, this person, Dorothy Reed, was coming up with staging for cancer. And so cancer staging, as you all probably know, it goes something like this. You have a stage 0 where these cancer cells are found in their earliest form, and then through to stage 4 where cancer is spread to many different parts of the body. You've got increased mortality risk associated with these stages. Right, great system, very simple, applied across all cancers. It has like a lot of different committees and things that decide on where people should be in these stages, but conceptually it's a very simple thing. So what you're trying to do there is you're trying to prevent progression if you've seen the stage that the person is in. So if they're in stage 1, then you want to prevent stage 0, then you want to prevent stage 1. You want them to go into remission and you want to cure them of the cancer, for instance, at this stage. It's the same thing for all of these different stages because of the increased mortality risk. The other thing that it's done, this kind of staging paradigm, is that it's introduced a whole prevention paradigm for health. So instead of getting people in this stage here, we're trying to prevent cancers, and that's widely known. Like we do national screening for things like bowel cancer and other conditions. And that's because if we catch someone early, then we've basically got a better chance of curing them of the disease or making them not progress. And it's this kind of staging paradigm that, if you think about it, do you have a good model of this for mental illness? What do you think about mental illness? Mental illnesses can get this bad. They can cause death, like I just showed you, but we don't have anything to tell us, what stage someone is in when they come into the clinic. How do we allocate resources? And if you think through how we're doing that, the answer is kind of concerning. So this is Orygen, and it's the largest youth mental health research organisation in the world. This is our service network across Australia. This is the largest youth mental health service network in the world. It's the largest per capita and also the largest by volume, I think, of integrated services with an integrated health registry system. So integrated ways of acquiring data. It's centrally governed, and most of it is called Headspace. What we do at Orygen is a lot of research. We a lot of clinical work, so we provide primary, secondary, and digital clinical services. We have 20 professors and 150 research staff, and we do a lot of translation work and are generally considered world leaders in translation. For instance, we've now changed the paradigm of treating people that used to be from 18 and above in adult services and below, I think it was 14 in pediatric services. We've changed it now and put it all together so that people from 12 to 25 come to our services instead. We think that that's much more logical than cutting it up over all of these different periods of life, because we consider that 12 to 25 is one developmental period. That's just one of the changes that we've made at a policy level. The other thing that that people have been doing all over the world is a lot of stage-based research. So looking at different stages of illness across in research projects. These are just some of them that I've worked on. Yet we still have this vicious cycle. So 90% of these places report a significant concern of discharging complex high-risk consumers in distress. I'd like you just to think about, would you give someone with stage 2 cancer a stage 0 treatment in these kinds of places that we have? And would you discharge people with stage 1 cancer? And if the answer is no, well, then why are we doing it at these services? And if you're questioning, which you definitely should be what I'm saying, and thinking, well, it's not as deadly as cancer, you'd be totally right. But the thing is that it is pretty deadly. So these conditions, at least like bipolar, you've got a suicide rate of 10%, 10 to 20%, psychosis has 13%. On the right-hand side, you've got the number of years of life lost. So that means that people with more serious and mental illnesses will die on average that much earlier than the population. So, this is for schizophrenia, it's something in the area of 15 years, 20 years. So you've got a 20-year gap in death, which to me is pretty serious. That is a pretty serious condition. And people will say, well, it's to do with, their health, like they smoke and things like this. But obviously all of that stuff is to do with the actual mental illness that they have. That's the most, important thing about their presentation. You can't separate the schizophrenia from, the smoking and the sort of health consequences. And so, there's this vicious cycle that is being talked about at the moment with increased mental illness and then unmeetable demand and poor clinician confidence and staff burnout. And it's these two things that I think that AI can have an effect on. Because as I indicated to you before, it's really difficult to know how someone is going to turn out, what their prognosis is going to be. And as I said before, the prognosis is what we're making decisions about, whether to discharge people, whether to give them psychiatric treatments, whether to refer them on to secondary care. All of these decisions, from the clinician up to the government, are based on prognosis. What can we do? Well, we've got to break the cycle. And we have talked to clinicians and consumers and services, and they've said a lot. And there's a lot of things that we can be doing and that we are doing in the community. There's two that I'm interested in, which is modernisation of the health service and then individualisation. So making things more personalised to people overall. And that's from the Royal Commission and also the National Review of Mental Health. And when we interview parents and also their kids, 85% want full and early disclosure of diagnoses and shared decisions around risk. So, you know, one of the concerns is that, well, if you tell someone that they're going to develop psychosis, then, you know, aren't you going to harm them? And so we did research on that, and, you know, at least they think not, you know, they think, well, we want to know, you know, that's important information for us. So we want to know things like the prognostic prediction. We want to know what treatment is matched to what individual, which is a prognostic, you know, problem in essence, interacting with an intervention. For clinicians, you know, we want personalised profiles so that they have more information that they can use. And that's probably the most important part of what I'm going to talk about in the third component of this talk, which is trying to give clinicians some more tools to work with. And then even in pharmaceutical, we need more targeted trials. So they need some sort of stratification that can sift through all of the heterogeneity in populations in order to target drugs effectively, which honestly, it has been the history of psychiatry for the last 200 years. You know, epilepsy was a psychiatric condition before. Wilson's disease was a psychiatric condition. There's a lot. There just hasn't been that many in recent times, except for NMDA receptor encephalitis, which is a, you know, interesting one. There's a book called Brain on Fire. I think that artificial intelligence could help within our services and maybe across the world. And before I describe it, I'd just like to say that we've been doing quantification of risk in medicine for a really long time. There's a nomogram, saved a lot of lives during one of the other historical pandemics in the world, the polio epidemic. Then they're used all the time in clinics all over the world for things like heart disease. And if you go to a clinic now, a primary healthcare clinic, then chances are, if you're over 40, a doctor will put in your details and tell you your risk. So we've been using these kinds of algorithms for quite some time. And artificial intelligence is just an extension of normal statistics coming from a bit of a different perspective. So this is the perspective that I come from. I come from the perspective that AI started with McCulloch and Pitts and then continued with Rosenblatt, who was a psychologist trying to model vision. And I described it before as a computational strategy that automatically determines or learns the methods and parameters. So instead of having a fixed sum like we did in the polio epidemic, there is no fixed sum for mental illness. And so we need something that's more probabilistic. And often we need something that is more flexible than a regression or a Cox regression that is usually used to calculate a risk calculator. So back after Rosenblatt introduced the perceptron, there was massive media fanfare regarding the potential consequences of this, and one of them was machine psychiatry, which is pretty interesting in 1961. So you can see there that the clinician is there, and then yeah, these lights are detecting moods, and this is a lie detector and analysis prompter. So there were these ideas that AI would solve everything in the world, and they were even installed by the Cuban government in their security department. They had an AI room, and none of that worked out. The only thing that really came from that was also a lot of fear. So, you know, these are some older articles. This is just fear about like technological innovation. AI, basically, the thing that came out of that era was a lot of really interesting and fundamental science, and also a little bit later, the ability to detect postal codes in the US, and that was then used. But everything else didn't really work out, and we went through an AI winter for many, many years. But it's got new beginnings now, and you know, it's integrated into our daily lives, and it's revolutionizing. I would say that it's revolutionizing some areas of healthcare, like radiology. Anything where a computer needs to look at a digital image, or a person, sorry, needs to look at a digital image. Turns out the computers are pretty good at looking at digital images on their own screens as well. There's been 512 FDA approvals and one in mental health. They're used widely across Victorian hospitals. If you go in and have an MRI, then you've got a good chance that an AI will be looking at your scan. So what does it mean in my case? Well, it means that you could take a questionnaire and then you could ask a question like, will this person have a psychotic episode? The AI will say, yeah, their symptoms fit the prognostic pattern. And this pattern is correct 85% of the time. And this is a potential pattern in different colors here. So by a pattern, what I mean is just coefficients on certain variables. I mean that some variables positively influence the outcome, and others negatively influence the outcome, just like that Venn collection of Venn graph diagrams that I showed you before. So it's just the embodiment of that, or the structural, or the equation for that, that image that I showed you before. The thing with AI, and the reason that it's been really great in radiology, is this is a brain. It is an MRI scan, and this is what I've worked, a field that I've worked in for around about 15 to 20 years now. If you reduce the dimensionality of the different voxels, the volume elements of the brain, you've got about 100,000. And with a lot of different disorders in mental health, but also in other areas, it's impossible to really tell whether some change in the brain is relevant to the clinical picture with your eyes. And so it means that what AI has allowed us to do is to expand the so-called multivariable space or dimensionality, such that we can detect similar patterns like this here that we've been doing for many, many years, like from the 50s that I showed you, but in the brain space. And so that means that we can detect, you know, areas of the brain that might be related to a particular outcome or not. This is what I talk about when I talk about machine learning and pattern detection. And so this has been really popular. This is a review. It's the only review in youth for AI research that I published a couple of years ago. And you can see that obviously people are using it a lot. But I don't need to convince you of that. It's across different fields as well. So prediction of existing targets and discovery of new targets as well. So, you know, we've got a situation where we're in a crisis and we have in Australia this centre that is the largest in the world for youth mental health. That youth mental health is in essence all mental health, because if we prevent it in youth, then we'll probably prevent it in adulthood as well, or we have a good chance at it. And so we are the ground zero here in Australia for this problem. And we've got the tools. So in my opinion, we need to act now. You know, this is our possibility, like our chance in Australia right now here. You know, I think that we need to get ahead of a potential wave of tools that might be released in the next few years, and that we can do it better than anyone else. And so here's one plan of how to get it done, but you guys can think about how to get it done yourselves and try and do that. And, you know, contact us or me or your friends or whoever, join the mission in any way you can. This is what, you know, I've been thinking about for the past year or so, or 2 years since I've been back, trying to translate this kind of research into the clinic. I think that we need three different components. Firstly, we need to develop algorithms. So we need to just develop stuff. To do that, I'm involved with these grants. The next thing, we need to create devices. And this is where the MRFF, one of the MRFF comes in. And then thirdly, we need to test those devices to make sure that they're safe and ethical. Let's start with this one. I'm just going to outline some of the advances that we've made and what's existing right now. So this paper outlined a question or answered a question: can we supervise machines to learn how to predict social functioning with clinical and brain data? So you took that clinical data, we found some patterns, and we also found some brain patterns that predicted social functioning, which is actually really important for young people. If you ask a young person with psychosis, which is hallucinations and delusions, like literally they could be hearing someone say that they should be killing themselves. If you ask them what's really important to them, they say like, oh, I want a girlfriend, I want relationships, I want my friends back. These kinds of things. It's a bit heartbreaking. And so, yeah, we investigated this kind of question, and we found that we could predict it around about 80% accurately in a sample that was multi-site across Europe that I'll show you in a second. What about this? So this is predicting the psychosis itself. So can we predict psychosis using similar measures as well as blood and as well as the clinician opinion? Because, you know, obviously we're always going to be integrated with clinician, and clinician will always have the final word. All we're trying to do with AR, or at least I am, is trying to provide tools to clinicians, which I'll go over in a second. And so with this, we found, this is just sensitivity and specificity or accuracy combined on the y-axis. And we found that we could produce a pipeline that starts with clinical data, goes on to the clinician's perspective, then goes on to bloods, and then goes on to a brain scan to create an accuracy of around 85% or thereabouts. So pretty good in this sample, which contained around about 7 sites all over Europe. It was a large European project. And so from that, we were able to create a tool online, and now it's in phase 3 clinical trials in Europe. And so they're trying to use it to direct therapy in people with psychosis and see if it can decrease psychosis. So that's one of them. What we've also done is taken another tool that's existing in the literature, and then we've validated across a lot of different sites. So this is, I was, I guess, the technical lead of this project and developed the models. You can see that we took samples from all around the world, and we got around about a 70% accuracy in those predictions. And you can also see that model online, the sort of what you call a pilot model or something, not to be used in clinic, but, you know, interesting to look at. So yeah, we think it's pretty generalizable. Here's some work that I've done with Andy Sito, and this is 15 headspace sites around Australia. A lot of different cases. We've got 119 transitions to psychosis and 152 intake variables. And this is one of the displays that clinicians can see at these sites all around Australia. And the results were this. So these variables are not from a study, so they're not as deeply phenotyped. They're just sort of what clinicians enter on the day. And the data is noisy, it has a lot of problems. But we still got a PPV of 18% and an MPV of 96%. You might say, well, a PPV of 18%, that means that if we say that someone's going to get psychosis, we're 18%, they're 80% likely that they'll actually get psychosis. So we're 80% likely that it's correct. You might say that that's really low, you know, there's no way we can act on that, but we're acting on that all the time. So like the bowel cancer screening in Australia, which is rolled out to the population and costs millions and millions and millions of dollars, has exactly the same screening accuracy. And, you know, I showed you before that if you get psychosis and then that develops into schizophrenia, then that's going to have really severe health impacts all over your life. And unlike prostate cancer or bowel cancer, sorry, it's going to occur really early in your life and rather than much later in your life. And so from that work and lots of other work that's been done by lots of other people around the world, this was funded. And I work really intensively on this project. It's called the Accelerating Medicines Partnership Schizophrenia, and it's got 100 million in funding. It's the largest cohort study in Australia at the moment. I think it's the largest that's ever been in Australia. We have $33 million US here to collect data from all of these yellow sites around the world. And then we're linked in with these orange sites and also with the data analysis hub. And the whole point of the project is to create risk calculators so that they can be used by drug companies to target people with therapies. So it's a really exciting project. We've completed baseline assessments, and it's got a 2-year follow-up, and yeah, it's going really well in terms of data collection. So that was the first part. We've got to develop those algorithms. What's the next part? We've got to somehow get them into care. So the problem with research is that it's research. It's not like production, right? You're not producing products. And no one in research really knows how to get their product to care. And so what's generally happening is that someone in research will create a company and then they'll try and sell their product back to the health service. And that's a fantastic idea. I think you should go and do that. It's really important that we involve industry in this equation. But the problem from a health perspective is that then potentially we're going to have like 100 companies that are coming to, say, Orygen, wanting to deploy their models. How do we assess that? Firstly, how does that work in our infrastructure? If each of them have a different thing on their mobile phone, then a clinician will, there's no way that a clinician will use that. So, you know, this is a looming problem that we can potentially solve. And there's also other inconvenient indicators such that of all of the FDA approved devices, and this is fast track approval, there's around about 75% that are not used. And that's due to the implementation chasm. So it's a big gap between, you know, producing something, forming a company, and then trying to get it to care. So that's also a problem. And so me and also the researchers here at the centre, we put together an MRFF to create a critical research infrastructure that would take clinical data, would have a data warehouse, an AI repository, and then would have an implementation arm. Overall, with the combination of those things, along with consumer ethics and regulation, we would try to offer a service for researchers. That service would be that the researcher could come with their algorithm, and then we would be able to put it through a pipeline that would lead to the RCT facilitation and ultimately implementation in care. So as I showed you before, we have this interconnected network. It's completely digitally connected. What I'm planning to do is or what we're planning to do is to take these algorithms and deploy them in that network in a systematic way. So you can break it down into different components. And I won't go through really the great detail of this because honestly, we're still working it all out. And if you're interested in this project, then I'll put up a link later and you can, you know, join along. But basically, we have an advisory service, and that consists of lived experience, ethics, economics, medical device regulation, policy, algorithm evaluation. And that sort of oversees everything that happens in the project. It has overall governance. We have an AI software system and then a co-designed web application interface, which would be general and would be, hopefully would be modular enough that we can add different components as they come. And then we've got training, education, and dissemination in order to train people in the use of this kind of infrastructure, and also AI safety, performance, and monitoring. And that's just simply because when you deploy an AI tool, generally there is drift. If there's changes in the model over time, you have to monitor that in order to see that it's still safe. And so what we want to do is really build a mission-driven lead product design pipeline in the first case, where we understand the needs of what clinicians want and what value we can add to their clinical workflow. Because really in this project, the buck stops with the clinician. This is where I'm trying to provide the help. Then we co-design with clinicians and also young people because they're the ones who are ultimately affected, and work with researchers who provide the tools. We integrate with data officers at Headspace and Orygen to ensure the linkage, and I do have partnerships with those centres. Then we deliver the solutions to early adopters and assess impact, and we iterate over that loop until we get something that works. So the other thing that we're hoping to do is to create a community of like-minded people that could be called the Organisation for Human Artificial Intelligence. This would centralize people who are invested in this, in the same or similar mission, not just for mental health, but maybe across other medical conditions in Australia. What's the last part? So I haven't got much time, but this is a very, very quick section. The last part is just testing devices. Once you've got the algorithm now, you've got the device, it's been produced with our fantastic MRFF, and then it's all prepared and ready for a clinical trial. And at the moment, a lot of these tools are probably in, say, phase 3, like I showed you before. So there's tools that are either on the market already, they're in the approval process by the FDA, or they're really ready for phase 3. And when we think about a clinical trial, I'd like to think about sports. Now, I don't know much about sports, but what if we played sport like we do a clinical trial? Let's just think about that for a second. So, you all must know clinical trials. They last generally for 5 years. And if we were to do it, play sport like we were doing a normal clinical trial, we'd build a stadium, we'd create some new rules, we'd employ all the staff, we'd start the 5-year game, but we wouldn't watch the game. You can't watch the game. And then you'd see if you won or not. You'd dismantle everything, and then you'd repeat that cycle. And so that means that people, you can spend your life and you'll only do a few clinical trials in that time. Because it just takes a long time. They're fantastic and amazing research designs. I mean, they've changed the world, that we wouldn't be in the place we are at the moment with health if we didn't have clinical trials. They are awesome. But for AI, and for these kinds of problems that we're dealing with a crisis and with an influx of a lot of AI devices, is this really going to work? That's what you have to ask yourself for these particular problems. Is this really, what we need? And a lot of people are asking themselves this across medicine. And so they're creating innovative trial designs, and this is a really big thing. I'd really recommend to go to a clinical trials conference. It's very fascinating because of all the new development and growth in that area. It's super, super cool and exciting, and people are excited about it too, which is also the other good thing, because often if you go to a stats conference, it can be a little bit, yeah. Well, you can make up the word in your head. But now, if you go and they're talking about this, it's actually pretty exciting. And so, yeah, it's basically just personalization and rapid clinical trials by making some good pragmatic decisions and using some really cool Bayesian statistics and other kinds of statistical approaches. So what's the future of AI integration with these 3 components? Well, maybe it's something like this, but maybe it's something different that you're thinking of right now, or you will in the next 2 weeks, and I'd love to hear it if you do. What's Lisa's expected outcome in 6 months? And then the AI says, maybe on the basis of Lisa's profile, there's an 80% possibility she'll recover. This rating is 75% certain. If you add cognition to this or another measure, then we'll increase the accuracy. And then the clinician might ask why, because that's a really important question. It might say something like, Lisa has a symptom and functioning profile that I showed you before, those profiles that most aligns with other young people who recover. For example, she has good social networks and shows low genetic risk, as an example. And so, yeah, that's hopefully, a future that is within our grasp. And I think that Australia is extremely well placed to do it. If hopefully I've kind of convinced you of that, and if you want to join the mission, or if you share in this kind of vision that we can make change with AI, and that we can kind of help people and reduce the mental health crisis that's occurring right now, then email me, or you can also go to this link and put your name on a list. We are for the MRFF hiring across different stages of the project. I have another MRFF that's interconnected with this that supports the data entry infrastructure of the different sites around Australia. and they're potentially hiring for that. I'm also hiring for an investigator grant that I recently got, yeah, and then we have another Centre for Research Excellence as well, where we have a position advertised actually right now, and we're wanting to hire in the next couple of months. So yeah, do get in touch if you're interested. And yeah, sorry, I've gone a bit over time. Hopefully there is enough time for questions.
Thank you so much, Dom. You convinced me.
Great.
That's a really big problem. Thanks for the analogy. So anyone in the audience have a question?
I have a question. So when we are dealing with cancer, why not deep learning? Because we have convolution neural network. So if we give images, it would be very easy for us to predict. So why not deep learning and why machine learning for this research?
For cancer or for mental illness?
For cancer, the bone cancer that we spoke about.
So the bowel cancer was just an example of what is currently being given in Australia, which is a occult. It's an occult blood test, basically. So a test of blood in stool, and so that has that kind of accuracy. Really, because it's just a binary decision. There's no machine learning there or AI there. You know, people are using deep learning, and convolutional neural nets were the first to, or that I know of, to produce really outstanding results in images. Yeah, and so they have been used for pathology, especially in order to screen things. Like there's one really fantastic example of eye disease and yeah. So, you know, they're definitely being used. What I put up there is just a blood. Yeah, it's a lab test. That's either a yes or a no lab test. And then that, yeah.
Thanks, Marcus.
So I'm actually going to follow up on that. So I think there's a big difference between the two, because in colonoscopy, we've got 99% detection rate, and the fecal monitoring is to make that as early as possible, because we also have a treatment. In your case with mental health, we need to have the equivalent to colonoscopy or the removal of the polyps. So the earlier detection, there's lots of questions around that. Firstly, is 12 early, or is it 4? As James Scott would say, we could detect these at 4, and we should be looking before 4. And then the other thing is, if we are detecting them, there's a difference in onset. So in cancer, we have high predictability because of the money invested. What would happen if you were to do yours every 2 years? And think about just like the bowel cancer screening, and think about that benefit. If we can actually work out the rate of detection, does that improve in any way the ability to treat?
So we would say yes, we've got a lot of evidence. So we really, at Orygen, not me, but other people who founded Orygen, they popularized something called the ultra-risk for psychosis state, and also the first episode psychosis paradigm. So prior to Orygen's work, people were generally identified with schizophrenia way too late. So we're talking between 2 to 5 years. And if you've had untreated schizophrenia for 5 years, then you have a poor outcome. And so we know that our treatments work. And we know that if we get them in early and we treat them early, in the case of psychosis at least, then we will have a better outcome over time. So we definitely don't have something as good as bowel cancer. So we can't remove polyps and then completely prevent the bowel cancer in a way. We have no physical embodiment of the disease, and so of the illness rather. It's not, in my opinion, a disease. And so, you know, yes. So I think that you're right, though, that if we had screening over time, then it would be a lot better. And also the other thing about this is that I'm not really talking about here population screening. I'm more talking about, in that case, screening in primary care. So that would be similar to going into a doctor and then getting a risk assessment for heart disease, and then acting on that risk assessment. And so sometimes I shift my thinking from cancer to more sort of systemic whole body disorders like heart disease in order to like understand if the similarities. I do put cancer up a lot, because, I, also find it's interesting. And that if we were to, have the same exposure as that field, then I think that we'd be able to get more towards what like the outcomes that they're experiencing in bowel cancer or other cancers, due to increased investment.
Okay, thanks. We have a question online from Stephanie Owens. Stephanie, would you like to ask your question? Let's see if she comes off mute.
Hello, yeah, it took me a while. Hi, I'm Stephanie from Microsoft, and I'm quite interested in your thoughts about the likely inclusion of youth mental health apps, either with or without AI, in the revised definition of SAMD in Australia.
I don't know what SAMD is. What is
Software is a medical device. I mean, it is exactly as you said.
Okay.
It's already considered as a medical device.
Okay. I mean, you'd have to sort of talk to me about what you're concerned about, but in general, apps are unregulated in the population, and that's a massive problem. And that's why we have the Centre for Digital Ethics, or AI Ethics, on board with Jenny Patterson in the MRFF. And so things like Headspace basically could be liable to, prosecution with the claims that they're making, because they don't have, evidence for them. And so it depends on what you're talking about when you're talking about apps. If you're talking about something like Headspace, which really has no regulation or control, then, the answer, I guess, is, it's sort of user aware, in that space. If you're talking about apps that do have, medical device regulatory approval, then at the moment, I don't know of any. There's one that is in development at the moment at Orygen, which is hoping to get approval. But I recently reviewed the FDA list, and I haven't seen any that, maybe you know of some that have got approval, but I haven't seen any that have approval. So at the moment, to me, the app space is a wild west, and it's really user aware for a lot of those apps, including the big ones like Headspace.
Yeah. Thanks.
Yeah, that's what I was looking for. Thank you, Dom. I think that up till now, the TGA has excluded youth mental health apps from its regulatory remit, but I think they are now looking to, actually mental health apps in general. It wasn't just youth.
Yeah.
In future, they are looking to bring that into scope. So I think it'll be interesting to see what developments might then occur in the marketplace. As you say, at the moment, it seems to me to be a bit of Wild West.
Yeah, that's super interesting. I didn't know that. So the MRFF in my work is not focused on apps. It's focused on providing clinical devices to clinicians. So it's actually in a different regulatory space. But but that's super interesting.
Yeah, thank you. Yes.
Don, great talk. So, one of the big challenges that you have with all of these predictive models is obviously the data that they're actually constructed on, and things like, patient symptoms, doctor's diagnosis, they can be pretty variable, pretty noisy over time, over different places. Obviously, and even in terms of the diagnosis that you're getting out, right? And obviously you're thinking about this when you're looking at all these multi-site big studies. But what are you sort of doing in terms of, thinking about standardizing some of those collections of data at the very start as a way of sort of cleaning everything up so that you're sort of making these models, making the inputs to the models more precise? Is that sort of part of this remit?
So it's part of the remit of the second MRFF that we have. So I don't lead that. It's led by someone called Andy Thompson, but I'm the tech lead as CIC, and basically that is the remit for the Headspace sites that you saw. So they're creating a clinical quality registry, just like exists in other medical fields, in order to capture the data in an accurate and precise way. So they are doing that. There's two other things to say about this. One, I still think that you can make predictions with noisy data. Everything is noisy, nothing is perfect. That's firstly. Secondly, the other area that I'm interested in, and I have someone working on at the moment, is trying to just use LLMs to enter data on questionnaires. As long as the clinician is asking the right questions, then we think that the LLM might be able to judge the magnitude of the symptom and then essentially fill out the questionnaire. The main thing with the clinical quality registries and clinician entry is that they are just too busy to do it. As I showed you before, it's a freaking, like, people are leaving in droves from our services. And then we're saying like, oh, can you please complete this 26 question questionnaire? They're thinking like, oh, this kid just killed themselves. Like, why am I doing this? And instead of seeing this person, makes sense, right? And so, yeah, we're trying to sort of address that by having like ambient AI like integration to reduce that burden. The other reason for that is that I really want to add value to clinicians' lives. So in order to enhance usage of any tool that's produced. So for instance, if you take the case of Heidi is a company that does medical note taking, and that has been amazingly popular and fantastic because it saves so much time. If we can go down that route, then that would be really beneficial for me. So if we can value add basically to the clinician's life, make it easier, faster, by, for instance, reducing admin burden, then that's always going to be a good thing for the patients and or the clients. Well, sorry, we call them consumers for some reason in Australia. Because then you've got more face-to-face time, which is a really important ingredient of therapy.
Well, thanks for that. People that are here, please stay after. We have refreshments. We have a half-hour reserved here. Spend more time with Dom and ask him more questions. But we'll ask everyone to give a final round of applause to our speaker. Thanks. All right, thank you for everyone that was online as well.